Thank you very much. Good afternoon. Great to see so many colleagues and friends here. And thank you to the organizers for asking me to speak about, and for having a whole session on TB, because I think this is a real problem as we look to the successes that we've heard about in HIV for children, although possibly not so successful in adolescents, more work to do. So my talk today is on what's new, making the diagnosis of TB in children. I'm going to focus a little bit on the burden of TB, look at current diagnostics, improved specimens for collection with a focus on induced sputum and nasopharyngeal specimens, speak about rapid molecular diagnosis, which has been the best advance recently, and then lastly a few words about other potential tests. So first of all, just to highlight the pediatric burden, and this is data from the 22 high burden countries. I've arrowed the countries in Africa, and this is percentage that are pediatric cases. And so you can see that for almost all the African sites, children constitute 15% or higher of the total TB burden of those countries. Now, this is with the caveat that we know that diagnosis can be difficult, that there's huge underreporting of cases. And in fact, even with these figures, the estimates are more than 500,000 cases of new TB disease in children in 2010, around 7.5 million cases of TB infection, and of the TB disease cases, only 35% are notified. So clearly there's a problem here, and there's potentially a big problem with underdiagnosis and underreporting. So why is this? And I think some of it relates to the diagnosis of TB, which can be challenging. All of you who work in the field know that clinical signs and symptoms are non-specific, that the tuberculin skin test gives false negatives, particularly in children whom we challenged to diagnose TB, HIV-infected children, malnourished children, very young children. Immune-based testing cannot, and this is PPD or interferon testing, cannot distinguish between infection and disease. And interpretation of chest x-rays is fraught, as I'll show you. Co-infection with HIV makes all of this much more difficult. And then, of course, microbiological diagnosis is not routine in children at all. And I'm going to try and address some of these issues. So why do we need better diagnostics? And I would argue that a confirmed diagnosis allows for a much more reliable estimate of the burden of disease. We've seen the estimates that I've shown you. It also allows for individualized therapy. It allows for treatment, appropriate treatment. Sorry, what am I doing wrong? Am I too close? Okay, sorry. If you can't hear, I shout, sorry. So in the context of drug resistance, it allows for appropriate therapy. And I think importantly, we need to acknowledge that in fact we have not done well in instituting rapid diagnosis of treatment in children. If you look at this study from Baragwanath Hospital, 40% of children hospitalized with what turned out to be culture-confirmed disease were discharged without treatment. Why is that? That's because culture confirmation takes a long time, 2 to 3 weeks. Children are discharged rapidly. And of course, in this time, the potential for worsening of disease, the potential for loss to follow up, huge problem. And I think this we can address much more effectively now that we have rapid diagnostic tests. But we really need to apply those rapid diagnostic tests to avoid this kind of situation. We are all familiar with the potential for rapid deterioration and spread, particularly in HIV-infected children, in infants and malnourished children, and we know about the pill burden, the issues of side effects, the issues of adherence in children who are asked to take multiple tablets, multiple antiretroviral, anti-TB, cotrimoxazole, etc. And so we don't want to unnecessarily put children onto TB therapy. So I would argue that it's imperative that we have better, stronger diagnostic strategies in children. So let's look at what we've got and how well they perform. Clinical diagnosis, firstly. And these are different scoring systems. Many of you are familiar with these scoring systems. They use clinical features, they use PPD conversion, and they use usually X-ray changes. And these are 9 different scoring systems. And all I want to point out is depending on which scoring system you apply, you'll get a completely different answer as to whether this child has TB or not. In this scoring system, 89% of children were diagnosed with TB using this scoring system, and it's the same children. Only 7% of children were diagnosed with TB. What's the truth? clinical diagnosis does not work well. In addition, we have increasingly appreciated that TB is in fact an acute disease. This old dogma of children present with 3 weeks of chronic cough, failure to thrive, etc. Yes, they do, but they only present there with that when we've missed the acute diagnosis, when we have not diagnosed them acutely. And we know now repeatedly in studies from Baragwanath, from ourselves, from Malawi, 8% of children with acute pneumonia have culture-confirmed TB. Now, we know that culture underperforms in children, so it's much more than 8% of children who are presenting with TB in the context of acute pneumonia. It's probably more like 20 or 25%. And I think we really have to shift our thinking from TB being a chronic disease to actually TB presents acutely in children, and if we miss that acute diagnosis, then it converts to a chronic disease. And this is a meta-analysis recently published, the same thing, 8% of children with pneumonia have culture-confirmed disease. Now, TB may not be the whole story in these children, and this is another dogma that is in change, and we're increasingly appreciating that pneumonia is not a single organism disease. It's not pneumococcus, it's not RSV, it's the interaction of organisms. And here, the interaction with TB seems to be a critical component, and whether TB is the cause or whether it's unmasked by another pathogen coming in is controversial. But the reality is TB is present in the lungs and is causing disease. So clinical diagnosis is not great. What about radiological diagnosis? And this is the Atlas of Radiological Diagnosis produced by the Union, a very, very nice booklet. And many of you will be familiar with the hallmark of, or the most common radiological sign that we use to diagnose TB in children, this donut sign, which is a sign of hilar adenopathy. You see it here on the lateral chest X-ray. And you know, we have some very nice features that we regard as a pathognomonic of TB. Over here, sorry, it's not projecting very well, but this expansile pneumonia compressing the left main stem bronchus, there, a miliary pattern on the second X-ray, and a cavitary type adult disease. But how well does radiological diagnosis perform? And the problem is it's non-specific. And that hallmark that I showed you, hilar adenopathy, has huge inter- and intra-observer variability. In fact, the inter-observer agreement is 30%. Radiologists agree 30% of the time as to whether there's hilar adenopathy or not. And in fact, that accuracy is not improved with a lateral X-ray. And of course, the high prevalence of HIV-associated chronic lung disease on chest X-rays makes this even more difficult. And so just to show you one study of how the interpretation of chest X-rays is highly inconsistent, these are 3 reviewers, very experienced reviewers, looking at the same X-rays. Sorry, this seems to be going. If you just look under positive, is it going well? I'm not using it properly. Here you'll see the first reviewer, thought that 11% of these X-rays had TB, but the third reviewer thought that 51% of these X-rays had TB. Huge variability. Again, we've got a problem. So let's turn towards microbiological diagnosis and ask, can we do better with this? And as you know, it's not standard in children, and I think there are a lot of prevailing perceptions. It's not feasible, possible, practical. It's not useful in children because they have paucibacillary disease, and it's certainly not possible in infants or very young or sick children. And, well, maybe you can do it in a hospital setting, but in primary care, absolutely not. And I want to try and show you that I think these are all old dogmas and that they are not true and that we need to change these perceptions and that we have a different standard for adults and we need to advocate much more strongly for children. So let's turn to some of the new advances, and I want to show you the results of some of the studies on better specimen collection and rapid molecular techniques. And I just want to highlight this by saying that I'm going to focus on induced sputum and nasopharyngeal aspirates, but underscoring this, I want to highlight, and this is particularly, I think, crucial to people in the field, that the quality and type of specimen that you get are crucial. You know, many times I'm told, well, we do gastric lavage, we do induced sputum, but we get nothing on children. Attention to detail and the way in which you collect these specimens is really, really crucial if you're going to get any valid results. So just to turn to induced sputum, many of you are familiar with this. There's hypertonic saline and a bronchodilator, nebulized children, and then either ask them to cough up their secretions, or if they're very young, like this child at Red Cross, then we suction them. And I'm going to try and quickly answer some of the questions that I'm often asked about this. There is no lower age limit from which you can get an induced specimen, induced sputum specimen. In an analysis of around 2,500 procedures, we obtain induced sputum in over 95% of those children. The median age of children is young, under a year. It is effective for microbiological diagnosis, and certainly for culture, a single induced sputum provides the same yield as 3 gastric lavages. It can be done in primary care, and we found an increased diagnostic yield from that. But importantly in children, and different to adults, you need to do repeated specimens if you want to get the optimal yield. And I'll just show you a little bit of the data so that you don't have to just take my word for this. So this was the first study where we found, in fact, that a single induced sputum provided 87% of our culture-confirmed cases compared to a single gastric lavage, which provided 65%, and that a single induced sputum was equivalent to 3 gastric lavages. 3 induced sputum provided a much higher yield than 3 gastric lavages. How young were these children? 50% were under a year of age. The youngest child was around 3 weeks. And importantly, a second specimen increased the yield by 15%. So you got 15% more children culture positive if you did a second specimen, and a third specimen gave you a 7% yield. Can this be done in primary care clinics? This is a study led by Anne Moore, who did this in around 300 children at Kuyasa Clinic in Khayelitsha. Slightly older, these children, around 3 years of age. She just did 2 induced sputums for culture and smear. Expert wasn't available. Induced sputum was obtainable in almost all children, and 11% were culture positive. A 22% diagnostic yield compared to clinical radiological diagnosis. 22% of these children with culture-confirmed disease would not have been diagnosed, were only put onto treatment once the culture results came back. And she taught the nurses how to do it and asked, well, how easy is it to do once they'd been taught and were doing the procedure? And if you can look here on the graph, Y1 and Y2, more than 90% graded this test as very easy or easy to do. And now, with the era of rapid molecular diagnostics, particularly Expert, which I know you're all familiar with, I think the imperative to microbiological diagnosis is even more so. And just to remind you, Expert is able to detect 130 colony-forming organisms per mil, so it's not as good as culture, which detects theoretically one colony-forming unit per mil, but it is a rapid PCR method that also detects rifampicin resistance. So, what are the results? In adults, it's very good sensitivity with around 70% for smear-negative disease, and that's because adults, and I've highlighted that because children are smear-negative. This is the first study of Expert in children, and you'll see here the sensitivity for 1 specimen, 57%, for 2 specimens, 71%, with, interestingly, a higher sensitivity, this is gone, in HIV-infected children, around 88%, compared to HIV-uninfected children. Smear, in contrast, as we know, performed very poorly. And again, the same pattern, that if you do a second specimen, you get a big increase in yield by culture, but an even bigger increase by Expert. Okay. This has been borne out by studies in Tanzania, which show whatever method you use, whether you use culture, this is Lowenstein-Jensen, Midget, Expert, a combination of tests, the more specimens you do, green is 1 specimen, light blue is 2, and orange is 3, the more incremental your results are for children. This is a summary of a meta-analysis of Expert tests for children. Basically, the bottom line is that sensitivity is around 65% to detect 65% of children with culture confirmation, but specificity is very, very high, 99%. So if it's positive, it's truly positive and it truly indicates a child TB. What about nasopharyngeal aspirates? These are a very attractive specimen because they can be done in primary care, And I just want to show you quickly the comparison of induced sputum with nasopharyngeal aspirates. Similar yield for expert, 71% versus 65%, but higher yield for culture. So the answer is, if you have an option, induced sputum is better, gives you more culture cases. If you don't have an option, do 2 experts on nasopharyngeal swabs. It's as good as 2 experts on induced sputum. Okay, and again, the incremental yield on nasopharyngeal aspirates was even more. So 1 nasopharyngeal aspirate is not going to detect the majority of children. You need to do 2. Okay, I'm being told that my time's up, so I'm going to quickly skip these slides and just say that this is a study, again, of expert in primary care in Khayelitsha, where we found lower culture rates. Only 8% of children had culture-confirmed TB, but 7% in fact were expert positive. So again, a role for this in primary care, and an interesting idea that if you combine specimens, induced sputum and a nasopharyngeal aspirate, you can get up to the sensitivity that I showed you for hospitalized children. You will detect around 65% of children with expert. I'm going to skip expert on stool because I don't have time. I just want to say that what's coming next is expert ultra. This is a more sensitive test than expert. The limits of detection are 5 colony forming units per mole. So it's getting very close to culture. We're very excited to have this. The adult results have not been released yet. They will be presented to WHO in February, and after that we're hoping that the pediatric trials can run. I'm going to skip other tests and leave you with the flu conclusions because Manette's going to throw me out of here. Microbiological diagnosis can be effectively done in children. Induced sputum is feasible and useful. Expert has been an important advance, but repeated specimens are needed in children. We need, however, a better point of care for rapid diagnosis in children. And I also think the upscaling of induced sputum and expert of children in health facilities has its own challenges that many of you are much more expert at than me: training, operational issues, monitoring, laboratory issues, and cost. But I do think we have to shift our thinking from that microbiological diagnosis is not necessary or possible in children to, in fact, we must do it. So how do we do it best? Thank you very much. Just want to